Hi, everyone, and welcome to our third week of breakout sessions of the virtual Iowa Governor's Conference on Public Health. We're so happy to have you here with us today. Whether you've been joining us every day or this is your first session, welcome. We are so glad you're here and learning with us. My name is Lena Tucker-Reinders, and I am the Executive Director of Iowa Public Health Association. Like I said, I'm so grateful you've joined us today and hope you will continue to meet with us every day this week as we wrap up week 3 of the Governor's Conference. This is our last week. We will total about 30 breakout sessions when we finish up on Friday. All of our sessions have been recorded and they are available on the IPHA YouTube channel. So if there's any that you've missed or that you particularly enjoyed and want to go back and listen to and share with colleagues, please do that. All the slides are linked in the description of the YouTube video, so check that out and share the good work of our public health colleagues. The Governor's Conference is put on every year by the Iowa Public Health Association and Iowa Environmental Health Association. We are both nonprofit organizations that depend upon membership and membership support to do the important work that we do. I strongly encourage you to join your public health colleagues and become a member of Iowa Public Health Association. Our mission is to unite and strengthen the voice for public health in Iowa, which is exactly what we're doing today. I also want to thank the sponsors and the exhibitors of the Virtual Governors Conference. Their commitment to public health in Iowa is paramount, especially in these times. The sponsors of the virtual conference are Aetna, AmeriGroup, Unity Point Health, the University of Iowa College of Public Health. Again, we thank them for their valuable support. We also have some virtual exhibitors. These are the people that you would have visited their table and chatted with them and learned about their work had we met in person earlier this month. So you would have checked out their tables then, so why don't you go ahead and check out their sites now. They are ACES 360, Champs Software, Des Moines University, Healthy Hometown, Iowa Corn Growers Association, IDPH, Bureau of Chronic Disease and Prevention and Management, and the Midwestern Public Health Training Center. So again, thank you to all of our sponsors and exhibitors. Before I introduce today's speakers, just a reminder that everyone is on mute, and this is to ward off any Zoom bombers. We've been very lucky and have hadn't had to deal with any of that, but we want to make sure that stays the case. The chat function is set to allow you to communicate with me. I will be monitoring the chat and pitching any questions that you have to the presenters at the end of their presentations. Regarding CEUs, I know some of you are here for CEU credits. Neither of today's sessions were pre-approved for CEUs. However, these sessions will be included on your certificate of attendance that you will receive at the conclusion of all the sessions. So in case you wish to seek credit on your own, these 2 sessions will be recorded for that purpose. So now, today's presenters, we do have 2 presentations today. Our first presenters are Guadalupe Chavez and Lauren Reist, and they will be sharing their work on reducing patient medication costs and saving time for busy primary care staff. And so with that, I turn it over to you.
Good afternoon. My name is Lupe Chavez. I am a 3rd-year student pharmacist at the University of Iowa College of Pharmacy. With me today is Lauren Reist. She is a 2nd-year student pharmacist at the University of Iowa and a Master's of Public Health student also at the U. Our presentation is titled A Proactive Approach for Reducing Patient Medication Costs and Saving Time for Busy Primary Care Staff. Lauren and I work for Centralized Healthcare Solutions. Our team consists of 4 pharmacists, 6 clinical pharmacy interns, and 4 administrative support staff. We are a pharmacist-led telehealth service that supports primary care clinics in the management of patients' chronic diseases and improvement of overall health. As part of our comprehensive service, we provide chronic care management, targeted disease state interventions, health promotion, shared medical appointments, annual wellness visits, and we also have a patient assistance program, which helps our patients reduce the cost of their medications and is the focus of today's presentation. The CDC reports that adverse drug events such as accidental medication overdoses cause 1.3 million emergency department visits each year. Older adults are 7 times more likely to be hospitalized than younger individuals for this reason. Additionally, if patients don't take their medications because they are too expensive, they can also end up in the emergency room due to uncontrolled conditions. The consequence of adverse drug events and non-adherence is the unnecessary spending of healthcare dollars. The good news is that both non-adherence and adverse drug events are both preventable. At CHS, we monitor patients who need help controlling their chronic conditions when they present, and when they present with cost concerns, our patient assistance program finds the most cost-effective medication. We call this process a formulary investigation. Often, we are proactive and complete a formulary investigation when we'd like to recommend a new therapy, even if patients don't present with a cost concern. Formulary investigations help our pharmacists recommend the best and most cost-effective treatment when it is indicated. As our primary objective, Lauren and I were interested in quantifying the amount of money our cost-saving efforts saved our patients on an annual basis. In our first secondary objective, we were interested in looking at the prescribers we work with acceptance rate of our pharmacists' recommendations related to the cost savings. And in our second secondary objective, we wanted to know how long we spent investigating and implementing the results of our formulary investigations. Our data was extracted from 2 reports we pulled between August 1st of 2018 through December 31st of 2019. At that time, there were 170 patients enrolled in our program, and our reports identified 74 unique formulary investigations that were completed for 60 patients during that 17-month span. We removed 2 interventions that were the results of a duplicate and an invalid entry, and that left us with a total of 72 interventions available for analysis. Here is our inclusion and exclusion criteria for our first objective. In order to quantify the amount of money we saved our patients on an annual basis, we only looked at those 26 interventions that were requested due to the current expense of a medication and where our intervention led to direct cost saving. The other 46 formulary investigations were excluded because those interventions led to indirect cost savings. We also excluded those investigations that did not lead to an actual medication change, or if the formulary investigation was requested for a vaccine cost estimate. A direct cost saving is when the patient pays less money than before. For example, if a patient was asked to pay $50 at the pharmacy and after our intervention now pays $30, they felt the direct cost saving of $20. An indirect cost saving is when there is a saving, but the patient does not necessarily see that change. An example is when a patient pays the same $0 copay, regardless of what medication they are on, even if it is cheaper or more expensive. An example is switching the patient from a $300 medication to a $200 medication. They're saving an indirect cost of $100. Now, if the patient agrees to switch to or start a new medication, that adds an additional expense to them, but in the long run keeps them out of the emergency room, then they experienced an indirect cost saving by not ending up in the emergency room for an uncontrolled diabetes, for example. You can imagine how difficult it is to calculate indirect cost savings because certain types are often costs that we are preventing. That is why we decided to include only savings that we could directly calculate as part of our project. When we looked at those 26 eligible interventions for 21 patients, we multiplied that month's cost saving by 12 to calculate a total annual saving of $27,846, leading to an average annual saving of $1,326 per patient per month. 7 out of those 26 interventions were GoodRx coupon cost savings. 19 out of those 26 interventions led to switching the patient to a less expensive medication that was just as effective. Some examples of this type of intervention include switching the patient from a brand to generic medication, or starting the patient on a medication that combines 2 drugs into one pill, or switching them to a medication that is on their local pharmacy $4 medication list. Now, I would like to pass it on to Lauren to talk to you about the methods and results of our secondary objectives.
Thanks, Lupe. So now moving on to our secondary objectives. Our first secondary objective was to discuss prescribers' acceptance rate of clinical pharmacist recommendations. Of the 72 interventions, we included 48 interventions where the therapeutic recommendation proposed led to indirect and/or direct cost savings to the patient and/or the healthcare system. The direct cost savings Lupe previously discussed, and some examples of the indirect cost savings we saw were recommending a vaccine, starting a brand new medication to optimize their medication therapy for their disease states. Typically, we work with diabetes, high blood pressure, COPD, and also starting smoking cessation therapy. Of the 72 interventions, we excluded 24 of those where the intervention did not warrant a recommendation to the prescriber due to patient factors. Some of these patient factors included things like the patient refused to add on another medication to their current therapy. The medication was too expensive for the patient, either due to they were still in their deductible and they were paying the full cost of the medication. The copay for the new medication was too high for the patient, or the alternative medication was not cheap enough or did not save the patient enough money to warrant them making a change. The overall acceptance rate was 97.9%. There was one recommendation out of the 48 that was not accepted. This recommendation was made to a specialist and not the primary care provider. Typically, we work with the patient's primary care provider as part of our chronic care management service, so we did not have a working relationship with that patient, but the recommendation was made to that provider due to the specialist prescribing that medication. So of the 48 recommendations that were made, 26 of these, or about 55%, led to direct cost savings, which involves switching to another drug in the same class that resulted in lower cost to the patient. Of the other 22 recommendations, so that blue on the screen, there were 19 of these that resulted in starting a new drug for a therapeutic benefit, and 2 of those were vaccines. Moving on to the second secondary objective, we wanted to report the time spent investigating and implementing patient cost savings. We included all 72 interventions, regardless of whether the recommendation was implemented or not, because the aim of this objective was to determine the amount of time that was spent by our staff to complete the interventions. So of the 72 interventions performed during the approximately 17-month time period that we looked at, 54 total hours were spent on these interventions, averaging about 45 minutes per intervention. If we look at this in a clinic standpoint, that time could be spent in 30-minute visits, which are your typical primary care visits, seeing 108 more patients. We were unable, with the limited amount of data that we had from the health system that we were working with, to assess how this time that we spent compared to the time that they were spending navigating formulary issues. But that's something that we'd like to look at in the future. Now moving on to our eliminations. So we primarily work with Medicare Part D beneficiaries. Medicare Part D plans include several phases, which can be seen in this diagram over on the slide, including a deductible phase, initial coverage, coverage gap, and catastrophic coverage phase. So direct drug costs at each stage are constantly changing, creating a moving target. With this moving target for direct patient cost calculations that we were trying to do to calculate firm and reliable cost savings was difficult. Drug costs for many of our patients, especially brand name drugs, can vary every month. As compared to the more traditional drug benefits with flat copayments, based on drug tiers, the Part D structure lends itself to less predictable direct patient costs. In addition, medication costs can vary from pharmacy to pharmacy. Miscalculations during data abstraction due to these factors could have occurred in addition to just due to human error. Not all of the interventions could have been documented correctly, over or underestimating cost savings. So early on in the process, we did not have a standardized format for recording the investigations, so looking at some of the earlier data yielded points that were harder to tease out. As a part of compiling this data, we have instituted a more standardized approach. And then, as we've alluded to multiple times, calculating indirect cost savings can be difficult. We were unable to do this, which may underestimate the impact we have on the healthcare system, including clinic staff salary, optimizing therapy that can prevent emergency room visits, and also overutilization of healthcare. So some next steps. We would like to continue to apply the clinical services to small primary care rural clinics who don't have a full-time clinical pharmacist on site, they have a smaller staff size, or they have a limited number of providers. So a lot of the clinics in Iowa that we work with are small rural clinics. Iowa is a very rural state, as we all know, and we're not alone in this country. There's a lot of places that have rural sites, or they have smaller clinic sizes. So by allowing us to come in, we can help bridge that gap where they cannot necessarily justify in their budget having a full-time clinical pharmacist when they may not have the budget for that. We would also like to assess patient and provider satisfaction with centralized healthcare solutions. And lastly, we would like to do some toolkit development with the things we have learned to help streamline and processes to increase efficiency. One of the things we would like to do is implement screening questions that would make it easier to ask patients if medication cost concerns are an issue for them. And if so, we could have that directed through an algorithm that would reference the quick reference guides that I'll talk about in just a second, and also ultimately could lead to a referral to the chronic care management service. So some quick reference guides that we would like to develop based off of our experiences through this process would be some guides to manufacture medication cost patient assistance programs, links to some common GoodRx coupon sites, and also ways to navigate calling pharmacy benefit managers. This is something that Lupe and I did early on in the process, and we did struggle with this, and we had another one of our coworkers come in who had previous experience with this, and we've learned a lot from him. Also, some drug formularies are available online, and this could be something that we could have a quick reference guide to those. That's when you're in clinic and you need to make a recommendation quickly and you don't necessarily have time to consult the chronic care management service. This could be a place to start. We'd also like to have a list of combination medications, which could reduce a copay from 2 copays for the 2 separate medications down to 1 copay for the combination. Lastly, we would like to thank our team. Our pharmacists, Ashley, Chris, and Rachel, have been very helpful in this process for us. Ashley has been especially helpful in helping Lupe and I navigate the process of submitting an abstract to the Governor's Conference on Public Health, as well as giving us tips along the way. And then our other interns that we work with, Reed and Sarah. Reed has been very helpful in this process as he does most of the formulary investigations now, if not all of them. Like I alluded to earlier, Lupe and I previously did them, and it was very difficult for us because we didn't have that experience, and we've learned a lot from Reed. We'd like to thank you for joining us today virtually, and I know this is not what we expected, but it is nice because we're able to still do this. We'd welcome any questions at this time, and I will add that if you are watching the recorded version of this, our phone number is listed there, as well as Lupe and my emails. We'd be happy to answer any questions, and our website's there as well. So what questions can we answer for you all?
Well, thank you, Lupe and Lauren. Such important work that you guys are doing to help drive efficiencies in the healthcare system. We do have a few questions that have come in, and so I'll read these to you, and then between the two of you, you can decide who's best suited to answer. The first one is just more process. How were your recommendations made to your primary care providers?
Yeah, so our current partnership consists of having electronic medical record access. And so our pharmacists are able to directly send the recommendation via EMR message, or even send a new prescription through the system and have the provider co-sign the order if they agree with it. Lena, I think you're muted.
Oh, I thought I'd turn it off. Okay. We're always learning, aren't we? Okay, this next question is about the toolkit specifically. And do you plan on passing the toolkits on to primary care clinics for them to utilize on their sites and then to refer to your program? Or are these for internal use only, or kind of how do you envision them being used?
Yeah, so I can go ahead with that one. So I think that right now it's something that we want to pass on to the primary care clinics that we work with, because there's a lot of times, like I said, we're not on site, we are remote, and so it would be helpful to have those things on site for them. So I think that'd be something that we would definitely utilize internally, because we do have students that rotate through our site. So just having a way for them to have access to those would be helpful. And then also passing those along to the primary care sites so that they have something to work with there. And also just a way that they can educate their staff too.
Good. So given where we're at now, and so many appointments have turned to telemedicine, and we've kind of now proven that this is a way we can operate within the healthcare system, how do you see your work or Medicaid payments and assessments being impacted by telemedicine if we continue to go down this way?
Yeah, I can add to that. So right now, the reason why we're pharmacists, and so Medicare Part B doesn't necessarily recognize us as providers. So we're unable to bill for these services directly. And so we have to go through these clinics so that they can get reimbursed for the services that we're providing collectively. And so as we continue to, telehealth, the technology has been integrated into the healthcare system, but it's also going to evolve. And so our goal is to continue to push these services, prove that collaboration improves patient outcomes, and hopefully at the state level, get that provider status. And eventually, in my lifetime, I hope to see us have provider status federally. I know a lot of states have been implementing amazing policies where pharmacists are able to prescribe in the community setting. And I think that as long as everyone keeps pushing for that and showing these patient outcomes, then it'll happen someday.
And so you talked about kind of the evolution of telemedicine and of practice and licensing and such. How do you anticipate your work evolving, like with this toolkit, with the study? Do you anticipate either passing this on to other students, or kind of doing a round two? Kind of what's next?
Yeah, I can go ahead with that. So Lupe is actually going to be leaving our service because she'll be heading out on rotations. And so kind of a unique thing about our business is that we have pharmacy students. And so we're only here for a couple years, and then we start going out on rotations. And so we constantly have new people coming in. So Lupe and I were here at the start of this, and then we've had a couple interns come in since then. And so I think that's one thing that is continually evolving, like you said, is, passing it on to other students. And I think that as we move on, we'll be able to see how this pandemic has impacted our clinical services, and see we've been evolving daily. We are all working from our homes and things like that. And I think that's one thing that we were kind of set up for, is we were a remote setting already, and so from the patients, and so we were calling into their homes. One thing we have seen change is that a lot of them are home because they are home. And so that's one thing that we've seen. And I know one thing that patients that we talk to have told us is that it's very helpful to have someone that can answer questions. And so they're really appreciative of us still calling and helping to kind of bridge that gap. So not only just the formulary investigations, that's just one thing that we do that I know patients appreciate, obviously due to cost savings, but there's so many other things that we do as well.
Great. Yeah, it's such a great service and a great partnership across the health sector. So thank you both, Lupe and Lauren, for your work, for presenting your work and sharing it with us all today. Thank you for those who wrote in questions to help further the conversation. Like Lauren said, their contact information is there on the screen, so I encourage you to reach out with more questions that you have. So thank you both again. Now we're going to switch gears, and we'll bring on Kelly Gerdes from Cerro Gordo County, Cerro Gordo Public Health. And Kelly will be giving us insight into the importance of building and maintaining cross-sector partnerships. So take it away, Kelly.
Okay. Thanks, Lena. All right, so my name is Kelly Gerdes, and I work with the Cerro Gordo County Department of Public Health. We are up in Mason City, Iowa, so northern Iowa. My presentation today is under effective partnerships and understanding what other sectors in our community need to establish effective partnerships and how we as public health can provide it. So I wish, part of me wishes that we were able to have this presentation maybe 3 months ago, so that now that when we're contacting businesses and other sectors right now around COVID-19, we may be able to have some of these tools. But nevertheless, I think now we have the interest of our other sectors, so when we have future requests, we can use these tools now. So a little bit about the Phrases Fellowship. I, along with 14 other public health professionals from across the country, were selected for the Phrases Fellowship. It is being sponsored by the de Beaumont Foundation and the Aspen Institute, both in Washington, D.C. These are some of the major community health partners at the national level, and they were trying to create this communications toolkit for public health, specifically for public health professionals, to help them better connect with community partners and keep public health at the table. And so the tools I'm going to share today are what these two groups have came up with, and we 15 fellows are the ones who are trying to spread the message on these tools. So today we're going to talk about what the toolkit includes. It includes information on how public health professionals can reframe our priorities to include better talking points from our partners' points of view. So how do we better communicate with the business sector or someone in the housing sector? Secondly, we're going to practice, or the toolkit will allow you to practice skills in crafting better public health messages that resonate with the public. Last year at the governor's conference, I remember that one of the keynotes was on how we need to repaint our picture more with the landscape approach versus the portrait approach. So we're not using the scare tactics or placing blame on an individual, but rather we're trying to get collaborative work from all different sectors to help create community impact and improve public health for our community. And then thirdly, I'm going to show you additional resources that the toolkit includes and how you can go about gaining those resources online. So the toolkit really is there to help give it's specifically built for public health professionals to help them better improve cross-sector collaboration. It's there to help sell the value of public health, give tips on how to approach your community partners, what kind of language to use, and show and demonstrate the demand that cross-sector collaboration is needed for our community to achieve health goals. We know public health can't move the needle alone, and it really takes collaboration to make it happen. And you know, right now our response with COVID-19 is a great illustrator of just how many partners and how many sectors have to work in the same direction for the benefit and health of the community. So the toolkit was originally set to be launched earlier. However, it's been delayed again a little bit because of the COVID-19 duties, but it will be going live in July this summer at phrases.org. So jot down this website, www.phrases.org. This is where you can find all the resources that I talk about today that you can use to help further your partnerships with your community partners. I would say this information is obviously good for any public health professional, but specifically maybe if you have public information officers or marketing professionals in your community, or community liaisons and stuff that work with facilitating different partnerships within your community, they will definitely find these resources most helpful. So again, why does public health need to collaborate? Obviously, we realize that the health of a community starts with upstream factors. And so that requires much more than just the health department addressing those factors to create improvement in the health of a community. So we need to involve housing and education and health systems, businesses, many different partners upstream to have an impact downstream on individual health. Oftentimes that leads to public health maybe not being invited to the table at the forefront, because many of those other sectors don't necessarily think of public health first and foremost when it comes to any of their community projects. So sometimes public health itself is misunderstood. A lot of people don't really understand what public health is, what we offer. Luckily, with COVID-19, our face is at the forefront, so more and more people do see a little bit of what public health is offering, but I think there's a whole lot more that is not seen behind the scenes. So one, we're misunderstood. Two, oftentimes we're uninvited to the table. In my work, working on built environment type of community planning things, we kind of have to invite ourselves to community discussions, and it's unfortunate. So how can we as public health be thought of more as a true player at all these different kinds of meetings? So we're always at the table with chamber meetings or planning and zoning meetings and that kind of stuff. And then sometimes we as public health are sending the wrong message. This is maybe more so in the past, but if you're moving towards public health 3.0, hopefully you're already focusing on community impact versus personal reasoning and responsibility. But this toolkit will hopefully help you craft messages so that you are being able to showcase why it requires investment of all different community partners to impact the health of an individual and the community. So the Phrases Fellowship utilize the Frameworks Institute out on the East Coast. This is an organization that does a lot of large research for how major organizations, major societies and foundations frame their mission and vision and their marketing strategies to best resonate with their target audience. And so they use their same concepts and went into different sectors of the community, different industries, businesses, healthcare, and asked them what they thought of public health, healthcare, all that kind of stuff, to help us better understand how people maybe misunderstand public health or don't understand the whole picture. So I have a quick video here that I'm going to show you. It's about 3 minutes. Really pay attention to about the minute 30 mark where they ask what is public health, because I think it's pretty telling of what most other sectors maybe thought of us. Maybe more so before COVID-19 was so prevalent, but it's just very interesting. So bear with me for this 3 minutes here and watch the video.
I'm curious how you would define health.
Well, health itself is the absence of disease.
How is your general body behaving? And
When you're not feeling right, when you're not feeling like you were or think you are, and you think it's time that somebody needs to take a look.
How are you feeling when you wake up in the morning? Do you want to lay back down or do you want to get up and go running?
Not being encumbered or restricted from a normal lifestyle.
When I think health, I think healthcare.
I would say access to healthcare.
Access to healthcare, so clinics and hospitals.
And having the access to health services.
Access to some place that will help you live well.
What would you say shapes how healthy or unhealthy someone is?
Their diet.
Eating the right types of foods.
Working out and making sure you're making healthier decisions while you're eating.
Diet and exercise and sleep. I mean, it's common sense. You go to the doctor.
A lot of people put off going to the doctor.
Your company can offer you the best healthcare in the world, but if you never go to the doctor or you avoid your problems, then...
Exposures to bad environments.
Places that some people can afford are places that really you have to decide, your life is in danger being there sometimes.
And a lot of your lower income communities are food deserts, and you don't have good full service grocery stores.
Landfills, people are getting high doses of
problem.
carcinogenics because it's leaching into the water.
If I were to ask you what is public health, how do you think you would answer that question?
It's
not an easy question to answer.
A lot of doctors have masters in public health, but I'm not sure what it entails.
If you work in the public health profession, aren't you concerned with policy or something?
When I think of public health, the first thing that comes to mind is healthcare for the poor.
Dealing with the healthcare needs of the indigent.
Certain facilities that are operated and funded by the government.
When I think of public health, I think about the CDC.
I think, first of all, the CDC and then the local Department of Health.
I think of the CDC. They kind of inform,
educated people about the different viruses and things they can catch if they don't protect themselves.
Identifying patterns so that certain things don't happen, outbreaks.
Like infectious diseases, and if the produce is tainted, then the public needs to be informed.
In the work that you do in your field, do you ever collaborate with other fields, people from other sectors?
Well, I'm on a board for the city. I do a lot of planning, volunteer.
I am a Girl Scout volunteer, and I work with a low-income community.
We get a lot of guest speakers.
Bring industry people in because at that point we're trying to get the students ready for the real world.
Well, we sell to people. Sometimes it's one of my customers, and this is a different line of work. Drug reps and are coming in continuously.
Have any of you ever collaborated with public health professionals?
They're the ones who can tell us that syphilis is on the rise. They're the ones who can tell us other infectious disease screening is usually helpful.
I mean, when the epidemic of the colds and flus, we have had people come and talk to our kids about how to keep themselves healthy.
To do immunizations, bringing the flu shots to the city colleges.
To make sure that everybody had their proper physicals, immunizations.
I'm curious how. Okay, so you guys are lucky that we're doing this virtually now, because if I would have done the breakout presentation, we were actually going to break up into small groups and kind of do that similar conversation and see how you responded to different questions. But I think it's very interesting, that video when they interviewed. If you saw in the bottom right corner, there was a little marker that showed what sector those individuals worked in. So if they were from business sector, a healthcare sector, housing, education, that kind of stuff. And basically a lot of them had the same responses to the different questions. So what do you think about health? And a lot of people put that, what keeps you healthy? When people think about health, they think about healthcare, not necessarily public health or community health. When they think about what keeps you healthy, they think about personal responsibilities versus maybe upstream factors. And then again, you probably all noticed the silence when they said, what is public health, for a while. And again, they come back to, a lot of the things that, and probably the same would be said right now, of disease surveillance, infectious disease, that kind of stuff. And obviously we as public health professionals know that there's so much beyond that in the scope of the fields that we work in public health. And so there's many different ways that we need to kind of resonate our messages to help unify what public health is and clarify what we offer. And to do that, we have to, what Framework says is adapt our messages to the frames that people have set. So if you're familiar with the framing concept, it's just a concept in your mind that says that the different values that you hold, the different experiences that you've had in the past, the environments you live in, definitely shape how you perceive or hear a message. And so we have to think about our audience and how where they live or what they've experienced in their past is it's gonna frame how they understand what message we're putting out there. So in the Phrases Toolkit, they use that concept to help them give it some resources on how we as public health can approach 4 different sectors efficiently and best to resonate with their frame of thinking. The 4 sectors the toolkit really dove into were education, housing, business, and the health systems. However, I just want to note that there are obviously many other sectors that we might collaborate with as public health professionals, and the tools in this toolkit can be used with other sectors. They just focused on these 4 to really build a lot of evidence behind, and when they did the research and the one-on-one and group conversations with these individuals, these are the 4 sectors they used. So first and foremost, in order for the Phrases Toolkit to be most effective with public health professionals, we have to use forward-thinking visionary thinking for public health if we're going to adopt this toolkit. It's very much a public health 3.0 kind of concept where we're moving more towards community health, community impact type of thinking versus, you know, that tried and true one-on-one public health classroom-based or individual-based approach. And so definitely if your public health department is not yet quite moving towards a 3.0 model, this might sound a little vague or foreign, but if you're in that forward-thinking vision of what public health is, this toolkit should really be helpful to you. So the first tool that you will find online is called Mapping the Gaps. It's a research-based toolkit. So what they did is, again, they used the 4 sectors, education, housing, business, and healthcare, did interviews, group sessions, all this kind of stuff to gather information. And the Maps the Gaps kind of pulls out the discrepancies between what we think they think of us and how we think of ourselves and how we perceive ourselves to others as public health. So for example, if we were speaking with someone from the education or housing sector and we wanted to collaborate with them, the first thing they think based on their frames and past experiences from these 2 sectors is, another collaboration with public health, that's going to add an extra layer of work to our plates. Rather than seeing the benefits of collaborating with us. So they may be a little leery at first if we don't, at the beginning of our conversations, show them how this is going to amplify what they're already doing rather than adding on extra work. If we're collaborating with the business sector, what they have found is that it's better to base it on some sort of transaction or tie it back into investment or helping them earn and support their bottom dollar. Mainly the business sector just doesn't really even consider cross collaboration with public health because they see us as an entirely different industry. And then the health systems think of themselves as the leaders of public health. And a lot of times public health is left on the wayside or on the sidelines because they believe they're in control. And we don't want to take control as public health, but we need to recognize when we go to them for collaboration projects that we recognize that they think they have a lot to offer, which they do, and we can't take over control of the meetings. So how to use the tools. Again, try to reference the value of the other sector when you're crafting your vantage point or your conversation points for your ask. So if you're working with housing, the example there is housing. The housing sector thinks that housing is foundational to health, which it is. So we really want to focus on, in our ask, recognizing that we realize housing is foundational and how will our collaboration help ensure that the housing is being addressed. If we're working with the education sector, we want to recognize that the whole child is addressed, so not just their health, but their social, emotional, and cognitive health as well. Again, the business sector, we want to point out any selling points or marketing tools that could benefit them through this collaboration, because again, their bottom line is their bottom dollar. The health system, again, we're trying to align their missions and their visions with cost efficiency objectives as well. So again, looking at the Map the Gaps tool, it goes into much more depth on the talking points you want to use so that you can approach the conversation from their vantage points and get their interest right away. I won't go through this whole list, but again, it's just more information a little bit deeper into how public health views themselves, but how other sectors view public health and how we can craft that conversation. The second tool in the phrases toolkit is around strategic framing. There's 10 suggestions when you go to frame your conversation, whether it's a letter, an email, a telephone call. These are the things you want to keep in mind when you're making that first ask for that collaboration. Strategy 1 is demonstrate that you're familiar with the other sector. So avoid broad generalizations. So for example, if you're going to work with someone in the housing sector, you just don't want to say your ask is, we want to collaborate with the housing sector of our community. You want to be very specific on what that organization is working in. Are they working with a homelessness population? Are they geared towards market rate development? Are they on low income housing or affordable housing? All those kind of things. Really get to know your sector and the subsector that you might be working with. Strategy 2, I think, is going to be a hard one for public health to adopt, but they have found through their research with other sectors that many other partners and the public in general does not understand the term social determinants of health. it sounds really foreign to them and something that they don't have personal control over. So rather, the Phrases Toolkit recommends that public health start using the term foundations of community health. And this is just, they found a better way for people to visualize how health is impacted upstream. So if you think of a foundation, it's usually building blocks that form the base of whatever you're building, the project, the built environment, whatever. So those different blocks are housing and air quality, all those kind of things. And so rather than social determinants of health, they believe that foundations of health will resonate better and help paint a better picture for the public and for partners who aren't really familiar with health. It also facilitates a preventative versus reactive way of thinking, and helps to tie community health to many different issues and therefore require cross-sector collaboration. So you really also want to avoid placing public health in a leadership role and show that we are just one of those cogs helping to build the foundation of community health, and use that upstream metaphor. Strategy 3 is to illustrate that the public health field is always transforming. So we are not the public health entities of the 1950s, 60s. We are transitioning into public health 3.0. And I think a lot of people probably aren't aware of that. So focus on new success stories in public health in your messaging and not overused examples. You know, don't keep quoting Jonas Salk's use of vaccine as your illustration of how effective public health is. You know, use really recent new success stories to help you. You know, luckily with any IDPH grants or whatever, they've really gone to their grant reports and such utilizing success stories. So hopefully you guys do have some good piggy banks already built up of success stories that you can use when you're trying to cross collaborate. The toolkit will also show some examples across the country too that you could pull from, but obviously local stories would be the best, and recent stories at that. Strategy 4 is to leverage what we would call pseudo public health professionals working in other sectors to help push your message. Example might be, you know, if you're trying to work with the schools to get some better surveillance and on some diseases with the schools, you know, using that school nurse, because they might have a little bit more tie-in of how that can be helpful to both public health and the school side of things. Obviously, you're not going to go in and just say, we need the nurse to start doing surveillance on diseases, because again, that just sounds like an extra layer of work for the school officials, but rather you're going to help frame that message and say, hey, this surveillance tool could help you guys reduce absences from students if we can catch diseases early and outbreaks early. And then they, again, can see the value in that because they are graded based on absenteeism rates of their students. So they can see the value of that collaboration. Strategy 5 is to use words of empowerment in your messages. Again, this is to make sure that the partners don't feel like it's extra work that we're asking when we want to collaborate, but it's rather we're just trying to energize or fuel up, power up, strengthen something that they're already doing and that they've already identified as valuable to their organization. So how can public health ramp up or empower their efforts already? Strategy 6 is to appeal to the value of investment. I think we already talked about this a little bit in the business sector, but health is a cultural value shared by everyone across all sectors. You know, every sector is definitely feels that health is important for their employees, for their target audience, their customer, their clients, whatever. So we do all share that value of investment. And so we just want to make sure in our ask that we can help illustrate short-term and long-term investments and how that impacts the community. And that's where the success stories come in under number 7, to highlight that cross-sector collaborations really are the way to go, and they provide the best outcomes and benefits to all the different sectors that are participating. Strategy 8, showcase public health data expertise. Obviously, we have a lot of data, and I think a lot of organizations in our communities don't realize how much data we collect from time to time, but that can be certainly a bonus to highlight in any of your asks. Strategy 9 is to consider using the GPS navigation metaphor when you're explaining how public health can help other organizations. So an example of this would be if public health is the GPS system in your car, and the car is an organization and they're trying to get to city A, but along the way there's a detour and you know, a downed bridge or whatever, public health as the GPS navigation system has the tools and can do some reconfiguring with data to help that organization navigate to city A safely. So again, it's just another illustrative idea to help people understand public health better. And strategy 10, I think this is the most important, always keep our messaging positive. I'm a public health educator and I work a lot in the physical activity nutrition realm of public health. And so obviously my world is all about the obesity epidemic and how we can impact that. And for the longest time, the information was always like, oh, the obesity trend keeps going up, you know, now we're at 60%, almost 70%, all this kind of stuff. And it's very disheartening. And I think it seems unattainable to even do anything about it. So if we can reposition our messaging to be more positive and aspirational, inspirational, optimistic, definitely I think it goes a long way than using those fear tactics. And so definitely try to stay positive in your information, and then give attention to solutions. Don't just throw out something's wrong, but not offer a solution in any of your messaging. Make sure that you have that idea ready to go when you do that ask. So those are the strategic framing tools. There's several other tools in the toolkit. One is a quick start guide just to kind of help you get going. There are framing cards that tell you kind of how to frame different messages based on what audience you're going to look for. Public health metaphors to use, so some kind of language that public health uses that you might be able to paint a better picture of using some other language when talking to the public. There's a chart about when they say they think. I'll show you here in a little bit. Common answers to tough questions around public health, and then sample emails and stories that you can use for success examples. So we're going to dive into a couple of these here real quick while you've got time. One of the tools is a quick start guide. So what it does, it says there's a list of things to avoid saying in your messaging, and then things that you should consider saying to advance your collaboration. So one, like I already mentioned, avoid saying social determinants of health, because it takes on so many different meanings with so many different organizations, and instead focus on foundations of health or community health, and really focus on the positive ways that each sector can contribute to building that foundation of community health. Don't generalize or target an entire sector. We already talked about that with the housing example, but really be familiar with those subsector groups and be familiar with their priorities. Maybe you need to visit their website, or, you know, do a little research before you do that first call or reach out to them. Don't talk in vague or abstract terms. Be concrete, give recent examples, you know, not past examples from 30 years ago that no one remembers or that have been used over and over and over again. Don't focus on the health challenges other sectors face. Show more so you want to show solutions on how you can help through either your data or your expertise or your knowledge, and fuel what they're already doing to help them. The answer to tough questions tools, here's a brief snippet. So what they do is these are some common questions that maybe you might ask, or another organization might ask of public health. And what the standard answer usually is that we would provide as a public health professional, but then it reframes it into an answer that we should provide so that it resonates better with that outside organization. So one example is down at the bottom, that idea sounds great, says the partner, but does public health have any money to pay for it? And usually our answer is no. But instead of saying no, we still want to try to get that collaboration happening. And so this tool would say, well, begin the conversations with the scope of the problem that can trigger crisis thinking, and be aspirational, that appeal to their value of investment, and emphasize that if everyone shares in the commitment of this project or this collaboration, everyone sees a cost reduction or cost savings or cost efficiency over the long term. And so we're not necessarily saying yes or no, we can't pay for it, but we're just saying how if we're all working on this together, we can accomplish it and not have to worry about does public health have money to pay for it. So just one example, but many different examples to different questions that are asked of public health when we want to partner. There's another tool that's called When You Say They Think. So this is a chart that helps public health professionals why maybe one of their messages didn't resonate with their target audience. So you can kind of go through down there. I won't read through any of these, but it basically says, when you say this, the sector or the public thinks this. And so what are some tips that could help us re-navigate that conversation and frame it better so that it resonates with what we want and gets the other sector on board and invested. Several more tools. I won't go through them all. Like I said, in July is when this toolkit is going to go live. It's at phrases.org. I'll say that again. But all these different tools are going to be there in much more detail, like I said, than I was able to provide to you today. Also sample emails, success stories, like I mentioned, from different public health departments from across the country that you can use to help when you're trying to start that cross collaboration with other sectors. You know, the big thing is we just need to ask. A lot of times we need to invite ourselves for a little bit before more partners start to realize the value of public health. But when we make that cold ask, we want to make sure that we're asking it in a way that sells to the other partner. And we do that by talking from their vantage points. And this toolkit is supposed to help us make sure that we can talk and resonate with our partners. Here's one example that I found that was local with the University of Iowa. One of the framing examples that'll be on the site, but one of the questions was proposed, we need to do something about binge drinking here in Iowa, specifically in college campuses. And a lot of times the rhetoric you'll hear when you're asking for cross collaboration with communities, well, that's a student problem, you know, it's all on the college and they need to figure out how to handle the situation. The president at the U of I several years ago used this as her rebuttal when asked, you know, what is the college doing? And she says, of course, students who drink too much are responsible for the problems they cause, but students are not responsible for manufacturing and marketing alcoholic beverages. They're not responsible for the excessive number of bars within walking distance of our campus, and they're not responsible for the price specials that encourage drinking to get drunk. So again, she's kind of using the phrases toolkit approach where she is saying how other pillars of the foundation, different community organizations and their approaches to business are impacting why and how much students drink. And so it's just not solely the responsibility of the college to curb binge drinking, but many different community and cross-sector collaborations are going to have to take place in order for that to be changed. So, you know, density of bars and marketing of drinking specials, all that kind of stuff all play a part into binge drinking. And so that just a good illustration of how cross-sector collaboration can help tackle a community health issue. Here's one on walkability. I won't talk about it since we're getting close to time here. So in summary, we'll take some questions here with the last little bit, but phrases.org is where this toolkit is going to be. It is, like I said, going to be launched in July of 2020, so a couple months here. Should have some really good, useful tools, especially if you're someone who does the crafting or messaging for your public health department, or you are someone who is always trying to be the convener or the organizer of community partnerships and coalitions. I think you'll find value in some of the resources here. Like I said, they vetted these with 4 of the sectors: housing, education, healthcare, and business, but they can be applied to many different industries and such, and I think you'll have just as much success. If you're really bored today, we would love to have you evaluate the toolkit presentation so that we can make it better as fellows when we have to give this and disseminate the toolkit more. So feel free to scan the QR code and take the evaluation if you'd like. And with that, Lena, we can take some questions.
Great, thanks, Kelly. This was such a phenomenal opportunity that you had to participate in this. And this is so timely. I've heard so much talking going on the last several days about communication and common messaging and strategic messaging around coronavirus and all the different sectors involved and health equity implications and everything. So the timing is great. One question is just the kind of the practical use. What experience have you had in Sarah Gorder County, whether it was with your, the process you guys have been through the last year with the starting up in the new building, or your own response to COVID-19 in your community? Have you had a chance to use these the phrases guidance in practical applications yet, and how has it been met?
Yeah, we've tried to a little bit. I would say more so we're just dabbling in it more with our social media posts and like I said, trying to be more optimistic. Right now with COVID-19, obviously there's a lot of personal responsibility messaging going out, and rightfully so. We want people to practice good hygiene and all that kind of stuff. But we're trying to really get in with our business sector and help them with surveillance and mitigation efforts and education. And, with COVID-19, it's kind of an easier ask because everyone's scared and uncertain, and so they're looking at public health for those measures. But even more so, like now when we go in and try to work with schools to get them to consider what they're going to do when they reopen in the fall. They're looking for that guidance and such. We can start to use some of these tools, I think, to help get all those school districts to the meetings and help us all collectively work on the same strategies rather than every school deciding their own thing when it comes back to reopening or getting back together. So just, again, using the tools and making sure when we make our ask or we're scheduling our meetings or wherever, we are making the ask from their point of view so that they see the value of it right away versus us just saying, hey, attend this 1 o'clock meeting for school officials and public health. But in that introduction to attend the meeting, we want to put in that ask of how is this going to benefit your school by attending? Or how is this going to benefit your business by participating?
And so in the focus groups that you all, or that the de Beaumont set up, and was part of that, did they, after asking them what they thought about public health and how public health served communities and such, did they go back and kind of try and use some of that new messaging? And were there those kind of light bulb aha moments, or how do they respond when
they did go back. So they did those initial things. I think that video that I showed was probably 2 years old, if not a couple years older. And then they went back with the new toolkit and they redid the focus groups and stuff to see if it resonated better. And that's how they came up with the final product, because they did find that these metaphors and these language things were what resonated best with the different sectors.
Okay. Do you know, will there be trainings, webinars, online things in addition to the toolkit, or is it really just here's the toolkit, kind of read it, self-learning, or what's the plan?
Yep, they are definitely planning to have some more toolkits, webinars, trainings. We as fellows right now are just kind of the guinea pigs on to go out and see the response at first to see what people feel they need the best of. Is it webinars? Is it in-person trainings? That kind of stuff. So come July, once it goes live, we as fellows are supposed to receive more information on next steps on how we're going to disseminate it either more. So likely, I myself will probably be going throughout Iowa or the Midwest region to hold in-person trainings probably too, once we have the live tools in our hands.
Oh, great. Maybe we can have you back on one of our IPHA Third Thursday Lunch and Learns with that. So are there any tools, here's another question, are there any tools that will facilitate advocacy, or is it more so focused on coalition building and then you take the next steps from that?
I wouldn't say there's any language specific to advocacy that I've seen so far. Obviously, I haven't seen the complete list of all the tools because it's not live even to us fellows yet. But I think some of the pieces you could twist for your advocacy efforts, especially on how you're crafting the conversations. I know there is one section, I didn't cover it on this, but it's meant for how public health can communicate with the public. So I think you could take that information and kind of well up some grassroots efforts if you wanted.
Sure. And then you work in local public health. You're very aware of funding restriction, or not restrictions necessarily, but limitations. And do you anticipate this being resulting in efficiencies in terms of budget, or is there going to be kind of startup costs, or where do you think is this going to?
Yeah, I don't think there'll really be a cost to using the toolkit or adopting or whatever. I think it's really going to be most useful for public health departments that are taking or moving towards the 3.0 approach. More futuristic public health that maybe some departments just are starting to learn about now, and not really there. But at Cerro Gordo, we definitely are trying to do more and more collaborations with community partners on bigger projects, and so. This toolkit, I think, is going to be useful because it will help us share the cost of those projects, because everyone's going to find the value of being a part of it. And so they're going to be more willing to invest in it. And it won't just be solely on public health to try to come up with the funding, which I think will be helpful. Sort of that, you know, capitalistic view where everyone has to share in the cost to share the benefits.
Sure.
So yeah.
Yeah, and maybe it will help kind of nudge some of those other departments that are you know, I'm sure reading and looking at the Public Health 3.0, wanting to get there, but don't quite have, just maybe for whatever reason aren't quite in that space quite yet, but wanting to get there. This might be that nudge to kind of help, you know, do some small wins, you know, partnerships, and you have that first success, which leads to more. So I think that this will be helpful to all departments, or all health departments. Regardless. Yeah.
And I failed to mention, I think in the presentation, but and maybe it said it in one of the slides and I glossed over it, but you know, a lot of us in the public health field maybe didn't go to school for public health. We've just kind of learned as we've gone, and so some of us don't maybe even feel comfortable approaching other partners because we feel like we don't have that background knowledge or the expertise to back up what we're asking. So I think this toolkit really does try to do a good job of trying to help a person educate and make themselves feel comfortable with making that ask and showing them what kind of ducks they need in a row for their ask. If they are someone who's a little hesitant, you know, to make that first cold call. I myself was in that same boat, you know, the first time I was told to do some cross partner collaboration, I was like, oh, do I just like randomly call someone and say public health, and they're automatically gonna be like, oh, public health, sure, I'll participate, you know. That's not the way it goes. And so for those people that are unsure of themselves or maybe their skill set or whatever, I think the toolkit will be a nice little treat for them to make sure that they get their message right the first time.
Yeah, agreed. So this last question is going to put you on the spot maybe a little bit. What partnership or sector have you been wanting to work with that you're hoping that this might kind of give you that push to make that cold call and form a new partnership that you haven't, that the health department hasn't had in the past?
Yeah, good question. Well, I'll give a couple examples. One I think is happening right now, a little bit because of COVID-19, but again, because we've been talking about this at the health department, but just hadn't got it off the ground yet. But we've always done surveillance with our schools for tracking influenza or whatever it might be. And we've always had this thought of, we really need to do this with our bigger manufacturing companies in the county, because obviously if schools are seeing it, the industries and manufacturing stuff might be seeing similar things, and how can we set up surveillance systems in those organizations too? And so we were about to make the ask when COVID-19 hit, actually, and now is, you know, we've got their ears, and so we could probably get this project going with relative ease, because, you know, we're starting to see some of the benefit of knowing if employees are sick or for how long or all that kind of stuff, and have that surveillance. So that was one thing that COVID-19 is kind of already forcing us into, but I think we were kind of planning using these tools. Another one is trying to get in with our community and zoning organizations with our cities. A lot of times I'll just show up at meetings, you know, as a public health professional, not invited, but obviously they're open to the public. But to get them to understand the value of having maybe a public health liaison on their committees regularly to provide some of that insight on the health side of things. And so how do we craft that message to those boards or commissions with a committee, with a city or municipality, to get ourselves on those organizations, not necessarily, you know, being a decision maker on them, but just being there for resources or data if they have questions about the projects and their health implications.
Great. Well, this has been so great, Kelly, and I know that everybody on the call is looking forward to this toolkit coming out, and there's so many opportunities that we have to kind of move forward in our health and all policies approach, and building those cross-sector partnerships, and moving upstream, looking at the causes of the causes, and all that work that we want to be doing, and that many are across Iowa. So thank you so much for presenting this. We're really looking forward to it coming out in July and seeing you again and learning more as we go. So with that, I want to thank not just Kelly, but Lupe and Lauren as well for their earlier presentation today. I want to thank everybody who's on the call, who's been sending in their questions and learning along with us here. I encourage you to go back and contact Kelly, Lupe, and Lauren if you have any additional questions that you want to follow up on. All of our presentations are being recorded, and they will be available on the Iowa Public Health Association YouTube channel. And the presentation slides are able to be downloaded from there as well. We do have more presentations this week, every day this week. I hope you can join us for the rest of this week. Here's our presentations for tomorrow, but join us every day as we close out the virtual Governors Conference on Iowa Public Health. And as I say, as I close out each session, we may be social distancing, but we are still together. We are a network, and we are colleagues dedicated to public health in Iowa. And every day you show up for these, you just reinforce that. So thank you very much, and we will see you tomorrow.